Hello, everybody, and welcome to our talk here on medical disorders of the liver. This is an update to a lecture that I gave a long time ago, back in 2013. So I figured 10 years later, it's probably time to do a little bit of an update, and I'm going to probably try and condense this down a little bit more so we can have kind of a quicker talk, sticking really closely to the high yield topics that you'll need to know, particularly for step 2. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right hand corner. I very much appreciate all the contributions I can get to help offset the cost of these videos, and I thank all those of you who have already stepped up to donate. I very much appreciate it. All right, now let's just do a little bit of a review of the liver, because this is important stuff to know. Because if something goes wrong with the liver, then we're going to expect disturbances of these things. So in order to understand the symptoms of liver failure, you need to understand what the liver does. And usually we think of the liver as the detoxifier, but that's not all it does. So number one, the liver makes albumin. Okay, so if the liver is not working properly, you don't have albumin, or your albumin is low, you're going to run the risk of edema and sort of the things that you would see in things like nephrotic syndrome, for instance. So albumin, very important. You can get an albumin lab very easily, and if you see that that's low, it points to liver failure. Another thing that it does, it makes coagulation factors, particularly, and you need to know this, 2, 5, 7, and 10. Now, the way I like to remember the factors is that vitamin K is 2, 7, 9, and 10. And the liver is 2, 5, 7, and 10. So we talk about vitamin K, it's 2, 7, 9, and 10. 2 and 10 will always be there. So if you remember 2, 7, 2 plus 7 is 9, and then 10. With the liver, it's 2, 5, 7, and 10. 2 and 10 are always there. 2 plus 5 is 7. And there's 5 letters in the word liver. So you can remember that 5 is part of the factors that are made by the liver. That's the way I remember it. Take it or leave it. The liver is also a major hub of venous traffic between the lower body and the right atrium. So you've got all those veins that supply the bowel and the intestines, and basically everything below the liver as far as the GI tract is going to go up through the portal circulation. That's important because when you're absorbing things, you need to also detoxify things, if we're talking about things like alcohol or drugs or stuff. So they're going to go through the liver. And so you've got all that blood coming up from below the liver through the liver, and if the liver is congested, then you're going to get backup, and that is sort of the etiology of what we're going to talk about, something known as ascites. And then, of course, the liver is a detoxifier. It metabolizes nitrogenous waste. Remember back to step 1, the urea cycle. It also metabolizes estrogens. That's going to be important when it comes to certain symptoms of liver failure. And then it also deactivates some pharmacologic agents or modifies them. Cirrhosis. So cirrhosis is a pathologic state of the liver, and it's caused by chronic insult and inflammation. So, you get one insult to the liver, not a big deal. But when it's over and over and over again, like constant chronic exposure to alcohol or to certain drugs or an inflammatory process, and it goes on and on and on, eventually you get fibrosis, and that is cirrhosis of the liver. Now, these pathologic changes are going to interfere with the ability of the liver to function properly, as well as the ability of blood to move properly through the portal tract. So blood is going to get congested below the liver, and that's what leads to ascites. The number one cause of cirrhosis in the United States is alcoholism, alcoholic liver disease. Cirrhosis is irreversible and incurable. So once you've got it, and you're going to have to live with the consequences unless you get a liver transplant. But that's got consequences too, because then you're going to be taking immunosuppressants the rest of your life, unless you got an identical twin. Cirrhosis always increases the risk of hepatocellular carcinoma, also colloquially referred to as liver cancer. Now, this is just a schematic that I drew, sort of highlighting all the things that the liver does, which we talked about, and then the consequences that can come from that. And we're going to go through a lot of these things. Now, this is ascites. Ascites is basically fluid that escapes from the venous circulation below the liver, and it gets pushed out and into the abdominal cavity. And so it's so obvious when you see it. You can tell that this is not a fat person. First of all, you look at them and you know that, this is not a fat human being. But also you see things like this where the umbilicus protrudes out. And if you put your hand on one side of the patient and push on the other side, you'll be able to feel a fluid wave. And that is characteristic of ascites. So when you see someone with ascites, the next thing you want to know is why. Why do they have ascites? And so the way that we do this is by figuring out the serum albumin-ascites gradient. Now, in order to do this, we need to be able to get a sample of the acidic fluid, the fluid that's in the abdomen. And so to do that, we get a periocentesis. And a periocentesis is just where we go in with a needle and we take some of that fluid out. We can analyze it and we can compare it to the serum. And so this gives us our gradient. So the serum albumin-ascites gradient is just a differential in albumin concentration. So it's the serum albumin, which we can easily get through a blood test, minus the ascites albumin, so the albumin concentration in the acidic fluid. Now, we would expect these to be roughly about normal. I mean, if you're just pushing fluid out from pressure, you're not going to push albumin out. And so the consequence of that, if you have a backup, if you have cirrhosis, just regular old cirrhosis, you're going to have hydrostatic forces, and that's going to force fluid only out. So the albumin is going to stay in the blood, and you're just going to push fluid out. And so what that means is with a high portal pressure, the albumin in the serum is going to be normal or maybe a little low, and the albumin in the acidic fluid is going to be relatively low. And so the consequence of that is that you're going to have a high serum albumin-ascites gradient. So if the SAAG is more than 1.1, then you know what you're dealing with is a transudate. Okay, you have mostly just free fluid in the acidic fluid. Not as much protein or anything else. So a high SAAG points to some sort of hydrostatic pressure, and that's typically due to portal hypertension as a consequence of cirrhosis, but it can also be due to congestive heart failure, in which the backup is not at the liver, it's at the heart, and everything is getting backed up below that. Now, on the other hand, and this should say exudate, not transudate, if you have an issue with the vasculature, or anything that's pushing protein out of the bloodstream and into the acidic fluid, then you're going to have a low SAAG. So in other words, what's happening is that the albumin is normal or maybe a little low, and the acidic fluid is going to be relatively high. And so this SAAG is going to be relatively low. It'll be below 1.1, and that points to an exudate. And so what we're talking about here is a serum and an acidic fluid that's about the same in composition, at least as far as albumin goes. And so we'll see this in TB, in cancer, with infections, and lots of other things. Now, all patients, as I mentioned, who have ascites should get a periocentesis, but another thing that we need to think of is one of the complications of ascites, and that complication is spontaneous bacterial peritonitis. So when you've got a patient who comes in with ascites and a fever, then you need to treat them for SBP because this is lethal. So we would treat them with antibiotics, but we would get a periocentesis to get a culture on that to see what we're dealing with as far as the pathogen. So if you got a patient with ascites and a fever, or ascites and severe worsening abdominal pain, then you need to get a periocentesis and administer antibiotics. Okay, we're going to run through now some of the causes of cirrhosis, and we're just going to do sort of an overview. I go into all of these things in more detail in other talks. First of all, chronic hepatitis. We're talking about viral hepatitis here. This is an infectious disease that attacks hepatocytes, resulting in chronic inflammation and fibrosis. And remember, that's basically the definition of cirrhosis. It's Hep B and Hep C that cause chronic hepatitis. You should remember that Hep A is acute only. You only get acute hepatitis with Hep A. It'll never stick around and cause chronic hepatitis. So the risk factors for both Hep B and Hep C are IV drug use, unprotected sex, tattoos, if you get them at a really shady parlor, or needle sticks, and working in healthcare, I suppose, can do it too. The symptoms, usually the patient is asymptomatic until they start to develop cirrhosis. So the history is going to be really important here. How do we diagnose this? We get hepatitis titers. So you should be familiar from step 1 with how those titers work, especially for Hep B. It's kind of complicated to know whether someone's in the acute stage or if they are in the chronic stage or if they had a recent resolved infection. You should know all those titers. But when you're dealing with chronic active hepatitis B, what you'll see is hepatitis B surface antigen, not antibody, antigen. That means that you have a viral infection actively going on. So Hep B surface antigen is indicative of active chronic hepatitis. With Hep C, it's fairly simple. So we just go for the anti-hepatitis C antibodies, which will be positive, and the viral load count, which will be positive or high. Now, for treatment for chronic hepatitis, it depends on the type of hepatitis you have. So all patients with hepatitis are going to get interferon. And with Hep B, what we do is we go for those nucleoside analogs, so lamivudine, adefovir, and so forth. With Hep C, we go for ribavirin or with combination therapies. So those are those kind of weird drugs that we don't really give for anything else, like sofosbuvir and glecaprevir and lots of drugs that are very difficult to pronounce. So you should be familiar with those. At least if you see them, you should know that they're Hep C drugs because they're only given for Hep C. Okay, primary sclerosing cholangitis. This is an idiopathic inflammatory disorder of the ductal system. So we're not talking about the liver here. We're talking about the small bile ducts. Now, ultimately, because you have cholestasis, you will have inflammatory changes in the hepatocytes, but the origin of this disorder is in the ductal system. Now, something that stands PSC apart from PBC, which we're going to talk about in a little bit, is that primary sclerosing cholangitis is more common in men compared to women, and it is also associated with inflammatory bowel disease. So that may be given to you. The symptoms are pretty nonspecific, fatigue, pruritus, jaundice, but you can also get a little bit of malabsorption and other cirrhotic symptoms can be present. As far as labs, you're going to have normal liver labs, at least early on, because remember, this is a problem with the bile ducts. But one of the things that will help is the elevated alkaline phosphatase, and that's part of your liver function test. Now, why would the ALK phos be elevated? The ALK phos is elevated because this is a bile duct problem. This is not a hepatocyte problem. This is a bile duct problem at its core. And so when you have problems with the bile ducts, it's going to elevate your ALK phos. So when you hear elevated alkaline phosphatase and you're thinking liver, think bile ducts, not hepatocytes. If you've got super high AST and ALT, that's when you think of stuff like hepatitis. But when you have things like elevated ALK phos, something going on in the bile ducts. Now, to diagnose this, you want to go for an AMA titer. That helps you differentiate it from PBC, which we'll talk about in a little bit. But you can also get an ASMA, anti-smooth muscle antibody, and a p-ANCA. Those will be positive, so you should know those two titers. You can also get an ERCP or a transhepatic cholangiogram. That will be definitive. That will help you visualize the ducts. The treatment here is bile acid binding resins. You can also do ursodeoxycholic acid. And the definitive treatment is a liver transplant. Now, primary biliary, this should say cirrhosis. Man, I must have been tired when I wrote this. At least I'm catching it. So primary biliary cirrhosis, this is autoimmune. Okay, we know what causes it. It's autoimmune. And this is a disorder, again, of the ductal system, and it results in cholestasis, which does ultimately lead to cirrhosis. But again, at its core, it's a biliary ductal problem. This tends to be in middle-aged women who have other autoimmune disorders. So PSC was men especially with ulcerative colitis or Crohn's disease. PBC is middle-aged women with other autoimmune disorders. Again, very similar symptomatic profile here. Non-specific, some pruritus or jaundice, ultimately going on to cirrhosis, but early on, very non-specific symptoms. You get your liver function tests. Again, this is ductal, so you see elevated ALK Phos. All right, you're not going to see the elevated ASTs and ALTs that you see in hepatitis. The diagnosis here, again, that AMA titer. Now, unlike with PSC, with PBC, we're going to see a positive AMA titer, and that basically gives away your diagnosis. However, the most accurate diagnostic test is a liver biopsy, but we typically don't have to go there. The treatment is the exact same: bile acid binding resins and liver transplant. Okay, so hemochromatosis. This is an inherited disorder. It's genetic, and it's a disorder of iron absorption. Basically, what happens is your body just absorbs tons and tons of iron. It can't regulate the iron absorption, so you just absorb tons of it. You sit down and eat a big steak. You're eating a lot more iron than you're going to absorb. But these people, they just absorb it all. And so the result is very high serum iron levels. That iron's got to go somewhere. It can't be excreted by the kidneys. So it's going to deposit in the liver, among other tissues, leading to a destruction of the hepatocytes and ultimately cirrhosis. The symptoms will be your cirrhotic features. These other symptoms will be related to iron deposition in other tissues. So it can deposit in the myocytes, leading to restrictive cardiomyopathy. It can deposit in the joints, leading to arthralgias. It can deposit in the skin, leading to hyperpigmentation. It can deposit in the pancreas, leading to a diabetes. And it can deposit in the gonads, resulting in a hypogonadism. Now, you'll want to inquire into the family history of cirrhosis, liver cancer, and liver problems because, again, this is genetic. And to diagnose this, it's really simple. Iron studies. Just like when we want to diagnose if someone's got an iron deficiency, if we want to diagnose if someone's got an iron overload, well, it makes sense. We do the exact same thing. So you get the iron level and the ferritin and the TIBC that we get hematologically to see if someone's iron deficient. And what you see is pretty much the exact opposite. They'll have a high iron level, a high ferritin, and a low TIBC. The liver biopsy technically is definitive, but you can generally diagnose this with iron studies and your clinical picture. The treatment is good old-fashioned phlebotomy. There is chelation therapy, deferoxamine. You can also use that, but this is really just the opposite of iron deficiency anemia. So with iron deficiency anemia, a lot of times the reason they get that is because they're losing blood. With hemochromatosis, the way we treat it is to make them lose blood. Go and donate blood, pull blood out of them. It helps drain out some of that excess iron. Now, when you have a high iron state, this is a common test question, you have an increased risk of infection with Vibrio vulnificus and Yersinia. Okay, now Wilson's disease is pretty uncommon, but it is also an inherited disorder, but this has to do with copper absorption and secretion. So copper will deposit in various tissues, particularly the liver, eyes, and the brain. Copper is toxic to the liver, so that's going to cause it to result in cirrhosis. The symptoms here are fairly nonspecific, but there are some features that you will see that you won't see anywhere else. And the big one is the Kayser-Fleischer ring. It's pathognomonic for Wilson's disease. And, for that reason, you're probably not going to get asked about this. But if you do, you should know what a Kayser-Fleischer ring looks like, because if you know that, you're going to get the question right. So what happens then is you get accumulation in the eyes. It doesn't really cause any ocular problems. You just see it. But then when the copper accumulates in the brain, it can result in movement symptoms and psychosis. And these patients can look schizophrenic. So you really should think Wilson's disease when there's cirrhosis and psychiatric features in a patient that shouldn't have either. They don't have a history of schizophrenia. They are not alcoholics. They're not doing anything to get cirrhosis. They just have cirrhosis and psychiatric issues. That's when you think of Wilson's disease. Do a slit lamp. Look for Kayser-Fleischer rings. Get a ceruloplasmin. So what you'll do is to diagnose this, you'll get a ceruloplasmin, and the ceruloplasmin will be low. You can also get a serum copper, but a ceruloplasmin is better. The treatment is chelation with penicillamine. This is the Kayser-Fleischer ring right here, and you can also see it right here. You got to be really careful to find this. Sometimes it's not as obvious, but if you know what this looks like, you'll get these questions right. Now, the alpha-1 antitrypsin deficiency is an inherited deficiency of a protein that is supposed to break things down. It's alpha-1 antitrypsin. I'm sorry, it's not a protein that breaks things down. It's a protein that inhibits a protein that breaks things down. Okay, so you're inhibiting a protein that breaks things down. So what's happening here is that if you have a deficiency of that, you're going to go crazy with breaking stuff down. And some of the things that you break down are going to be liver tissue and lung tissue. So the result of that then is you're going to get a degradation of liver and lung tissue, resulting in cirrhosis and pulmonary symptoms. And when you think of degradation of lung tissue, think of emphysema. Okay? That's caused by cigarette smoke. But alpha-1 antitrypsin deficiency is caused from having too much trypsin that's acting, breaking down lung tissue and causing an emphysema. So these people will get COPD. Typically, these patients will first present with emphysema. Think of this when you've got a person who's 35 years old, has never smoked a day in their life, and they're coming in with difficulty breathing, hyperinflation, and they do pulmonary function tests, and they show a pattern consistent with COPD. That is your typical picture for alpha-1 antitrypsin. Eventually, they're going to go on to develop liver problems, namely cirrhosis. So the diagnosis here is fairly simple. You get an alpha-1 antitrypsin titer. That's, of course, going to be low. And the treatment is enzyme replacement and symptomatic therapy. You're going to tend to their COPD. But very important, and this should go without saying, do not smoke. This is just kind of reviewing what we talked about. So this is a little cheat sheet for you that you can use to help you remember all the things that we talked about. And I would recommend one more thing that you that you should look into that we didn't talk about here, but I do go over in another video, and that's autoimmune hepatitis. Autoimmune hepatitis, typically we see it in younger women. Because it's a hepatitis, they're going to have elevated ASTs and ALTs because this is genuinely liver tissue, not bile ducts. They will have tend to have a positive ANA. They can have ASMA. And then the best way to diagnose this is through a liver biopsy. And the treatment here is steroids and azathioprine. So immunosuppressants, which makes sense because this is autoimmune hepatitis.